So I'm going to stop,
yeah.
if I can stop you right there. Harm reduction is not about items. It's about a process, right? It's about it's about changing the way people think about people who use substances, right? It's about tackling the stigma that people are facing every day, feeling illness in their home to the point where they're, so sick that they will die in their house, as opposed to dealing with the stigma of going to the emergency room and facing that scorn, or what they perceive to be scorn of our emergency room colleagues, either the security or the admins or the nurse or the doctor or anybody along the way, right? And that whole, if you don't look right, like if you don't, say, are you really sick, or what are you here for, right? Are you drug seeking? Because you were drug seeking the last time. You came about pain like 3 times in the last month, so I think this is, you're just looking for drugs, right? That, changing the dynamic of that engagement, that's what harm reduction is to me.
I'm here in a hospital setting, and I want to make sure that we are harm reduction capable based on what the current standards are, and that we can eventually adapt as those standards evolve over time. And if something is causing harm in any way, we have a way of adjusting how it's delivered.
Yes.
What do you think about that? That is a potential conversation problem.
That's a great discussion to have. I think that I think there's a lot of heavy lifting involved in getting any hospital, kind of harm reduction credentials kind of up to anything close to what the community is, and I think that's part of the work that.
So the community's doing it a lot better.
Oh, the community's always done everything better, right? I mean, it's easier for a community, right? It's sort of like, these organizations are kind of. They're large. It's sort of like, I compare them to kind of like a steamship or something, right? Or these giant freight liners and stuff. And, some little boat goes in front of them, and how daft are they to be able to move out of the way? Well, not very, right? They can't steer on a little bit, right? There's a lot of planning. There's a lot of work that goes to changing
That's a nice metaphor.
Yeah.
Where'd you come up with that?
I don't know.
No, it's a good metaphor. I like it.
But these are, there's our little friend. This is Coco.
Please stick to the content.
You've started something there. I think
so you got this big freight liner. It's going in a direction. There's these little boats there. The little boats do a better job. Oh, he's gonna kiss me now. Are we gonna be making out? Is that? I'm not gonna be able to talk. Should I just ignore him?
Yeah, just ignore him.
Is that the way we show love these days?
Yes, that's
okay.
So. Yeah, it's
right.
tough love. That's.
So you're saying that the smaller boats have the ability to do more, offer more, and they're more nimble in responding to the individual people that are drowning, or whatever metaphor we want to use.
That's correct. Yeah. They're able to they can change on a dime, right? So they can, but. 100. There's the bureaucracy of an organization that happens, right? I mean, in order to make change, and you've got an organization that it's a lot easier to make change when you've got, kind of 12 employees than when you have 5,000 employees.
Of course.
When you've got 5,000 employees, just think about what that looks like, right? You've got, I'm not picky on the unions, but even just, changing of work requires, it's not just one person, there's all these.
You have to go through all these different levels.
All these different
They're
levels.
really trying to protect that employee on the ground, but it's hard to make a nimble change that's needed if you're not flexible for that change.
Yeah, and and also there are safety concerns, right? So in a hospital, you've got you've got security changes. You've got pharmacy that's got an input, right? Pharmacy sits at these tables when policies are involved, and and then there's the professional organizations of all the different players that go through, not just the unions, right? So you've got the medical side of it. You've got the nursing side of it. So I guess what I'm getting at is none of this is fast. And as someone who sat at some of these tables, and as someone who's felt the frustration of the community, and someone who's worked in the community, I see it kind of from both sides. And so little things like we call it little, but it's not so little in a hospital if you're going to let somebody inject drugs in their hospital bed. That's a tricky thing.
Yeah, so maybe we need to rewind a little bit, right?
Yeah.
Because right now we're going to some of the barriers, right? And I don't think we've really maybe it would be good for me to hear from you why is it important for a large organization, a hospital setting, to offer some type of harm reduction support?
Sure. So in very simple terms, I'll phrase it another way. If you don't do it, patients don't stick around, right? Like that's, okay. And somebody will say, well, so what? That's their choice. Let them leave. Okay, fair enough. If they leave, their care is going to be interrupted, and they're either going to get considerably more ill, or they're going to pass away, and that's why.
Okay, so we have to offer harm reduction, so people who have medical conditions that could kill them or just reduce their health actually stay in the hospital and get care.
Yes.
If they're living a certain kind of life outside of hospital, when you come in and you just change everything, it may not be realistic to get them to stay. Okay,
correct.
Perfect. That's a very, very good reason. What do you think harm reduction is? Like, if you had to explain it to someone like me who doesn't know, like say, like I'm like, hey, I'm a doctor. Let me be harm reduction capable. Like what and obviously it's a complicated process, right? It's like explaining like equity, diversity, inclusion. Like make me equity, make me live a way where I'm including diversity and inclusion and.
Yeah, I mean harm reduction is such a broad term, right? It can mean so many different things. I mean, the most simple kind of classic definition of harm reduction is we're accepting people for the imperfect choices that they make, and which means that we accept that people are going to continue to use substances, and that's just a reality, right? Abstinence is not a realistic goal for many people.
Yep.
Right.
Yep.
And that's okay, right? We all make imperfect choices. You drink maybe too much coffee, and maybe whatever. Right? We all make imperfect choices, and
there's no such thing as too much coffee.
There's no such thing.
I've looked it up.
Good,
I've
good.
read about it, and
Right.
I've decided it based
Good.
on the data I've chosen to read and
Perfect.
the ones I've chosen to ignore.
Good. And as a community of kind of healthcare providers, we need to accept people and accept those choices as being imperfect, and that's okay. And we move on from that. And we still, I often give the example of, if somebody has diabetes and they eat a pecan pie and they end up, having consequences from that, do we stop giving them care because they keep eating pecan pie?
The challenge is that in certain facilities, there's certain expectations or decorum of behavior, so to speak. Like maybe, if you want to come in the hospital, you can't yell and swear at a nurse, right? Or you can't, I guess you can't smoke you can't smoke cigarettes inside a building, right? And then you shouldn't be smoking other stuff. And in order to inject drugs, if I remember correctly, you have to use a lighter, right? You have to use a lighter. You have to heat up the stuff. You have to.
You don't have to do that, but we suggest people do that for the optimum use. But you don't need to use a lighter. But you've highlighted a good problem with the lighter thing, right? Where it's like, okay, so do we let people? A lot of people these days that are using fentanyl don't inject; they smoke it. Right, that's a very common delivery.
The foils and stuff.
So if that's their chosen delivery method, well, there's all kinds of issues with oxygen in a hospital. You can't be using a lighter, right? So that's a good point, right? So there are limitations, and that's why we only have. I think there's only one hospital in Canada right now that Casey House is a wonderful place, but they have the only inhalation room that I'm aware of.
And then Casey House is partially community, right? So that makes it
yes. So it makes it a little bit easier, right, for them to do it.
Yeah, less structural barriers, right? And I mean, I shouldn't say these structural barriers because some of the stuff is there in order to preserve safety, right? Like safety of the whole group and stuff.
You are in a hospital after all, right? And you're in a hospital for a reason. So I think there are there's an expectation sometimes where, even as someone, I'm just speaking personally, someone who's navigated these services as a substance user.
Yeah.
And so I've seen it on both sides. Do draw some distinction from my community colleagues sometimes where they say, okay, they have to be able to do this. You have to be able to do this. You got to give them everything that they want. And it's like, I get it. But also, as someone who's been in an ICU 8 different times, I'm like, but I'm in an ICU, right? And I'm here for a reason. And I wouldn't want, I guess I would like the autonomy to make the decisions, I think. But at some point, there's part of me that says, I'm also pretty close to dying, and I chose to come to this hospital, so maybe I kind of want some of the best medical care I can get.
Yeah. No, and it gets tricky, right? Because with hospitals, with infections, with these life-threatening medical conditions, people get these pockets of time where they're a little bit confused, right? They might not remember where they are. They might not know what they need. And this is for everyone, not just people who use drugs. And so then the capacity and decision making is tough too.
Yeah.
And then the other thing with the addiction, as you know, and I've seen, is that people aren't thinking long term. So even if they don't want to die, they want to live. They're thinking about how to relieve that suffering in the moment.
Yeah, and maybe I don't know that there's an option of saying to my, to my provider, to my physician, and they're saying, I'm a little uncomfortable right now. Is there a way you can make me a little bit more comfortable? And like having that conversation can be very difficult for a patient, right? And I think,
interesting.
But as opposed to somebody serving me up a tray of meth or something, and I'm not. That may sound like an extreme thing, but there's advocates out there that say that that's what we should offer. That's what you're comfortable with. So I want my meth.
Yeah.
But there's a lot of consequences of me doing meth, and there may be interactions with the medication you're providing me as a physician.
Yeah, because the risk might change, right? It may be a different level of risk, and it's one thing when someone does that choice outside of hospital. It's another thing when they do that with us in front of us, right? And we're giving other stuff that can alter the risk even a slight amount.
Right.
So actually, that was really nice. So I just because I'm just trying to frame it in my mind, and I think we're gonna have to have 3 or 4 conversations about this, unfortunately, right? Because I'm still grasping what the full body of work is for it, and then I'm also trying to figure out what's that smaller portion of that's worth going through all the tables to fight for, right? Like it's because it'll end up being like a negotiation like process, right? Because you can't just roll out everything for everyone. And one thing I did want to make, which I'm going to write down because I think this word is very, very important. It's the comfortable. And so when I go in and see any patient, right, who comes in, especially if they're using opiates or other substances, I'll say, hi, my name is Wiplove Lamba. I'm a physician. I help people with pain who use drugs, and I try to help them be more comfortable. I sometimes adjust the methadone. I sometimes adjust the buprenorphine. I give them pain meds. I say, what can I do to help you feel more comfortable? That's actually and we haven't talked about this separately, but that's literally the line that I take. Yeah. And then I figure out what they need. I reach out, I call the pharmacist, figure out what I can give them, and then boom, it's done. And because I'm a little bit overly concerned, I think, about tolerance, I haven't fully appreciated how potent the new fentanyl is. But also the other thing, JP, is that when people have severe medical conditions where they're required to come into hospital, they may not have the energy, right? So they may not have the energy to use as heavily as they had the last few days, and then their lung capacity changes as well. And so it's almost like I try to start lower, but I try to ramp up quickly whatever we're giving them, right? So for example, there was one case where the person was on, I was told 150 milligrams IV of hydromorphone twice a day. And just to give you relative things, so normally when someone comes in, we give them half a milligram every 4 hours, right? IV. And so this guy was on 150 BID, but when I called the places, I found out the person only got 2-3 doses in the last week. Right, so something else was going on where the person couldn't show up, and so it was this whole sort of a process to figure out what to give, how to give. I mean, my point is that there's something in the making the person comfortable.
Yes. Yeah, and I think you touched on, really. I mean, this is getting really deep into the weeds, but navigating some of these folks that are in safe supply programs when they get in as an inpatient, I think that's probably beyond the scope of our talk today.
It is, yeah, because I guess that's more like a specific clinical example.
But that is a very difficult, road to navigate for many different reasons, and we could probably do a whole talk just on how to manage that care, and it is something that from a hospital perspective that we are struggling with constantly to keep those patients, to keep them in the program, but also to keep them safe, keep them alive, because sometimes these safe supply numbers are off the charts typically, but then we don't know what the use is, if the use matches the prescribed amounts and all that kind of stuff.
So the two things that have stayed with me so far, I mean, other stuff has as well, is that, harm reduction is a tool that's essential in the hospital setting. because we want people to complete their medical care.
Yes.
Right. And it starts from a place of acceptance of whatever lifestyle or personal choices people have made. And regardless of whether or not those choices are contributing to their problems, we do everything we can to make sure they get that best medical care. And one of the key things that's incredibly important is how to help this person be the most comfortable possible so that they'll stay during that course in time.
Yes. Yeah, exactly.
Yeah. And then the other thing is that there's a lot of structural barriers, and I think that we might have to leave for a little bit later, because for today I really just want to get a feel for what to offer. And in the last 5 or 6 years, there's been a huge push for naloxone. It's changed dramatically, right? So with naloxone, all the pharmacies, you can just walk in and pick it up. Naloxone's fascinating, because we always talk about giving to patients, but you can't administer naloxone on yourself,
right?
Right? When it's for someone else, right? So we're literally giving to somebody where they're either going to have somebody else administer it or so forth. And then every now and then you'll hear a story where someone's like, "Oh, I was using the fentanyl; it was so strong, I had to use naloxone." And you're like, okay, something's not. So naloxone was the first, I think, a medical invention of harm reduction in the hospital setting that was a bit readily accessible, right? And it's gone to the point, I think, that other facilities have this stuff too.
Right, and even that's a great example of something we struggle with, right? So, and I think it's almost hopefully getting to reach the saturation point that anyone who wants it gets it, right? Who has it now, basically.
Well, I mean, I think the argument is that people can get it; they just have to go to the pharmacy and they pick it up and they get it.
Yeah. So, and if you go to a hospital pharmacy, you may be there for 2 hours waiting for an appointment to be told how to use it.
Oh, because they have to teach you. They can't just give it to you without the teaching.
Well, if you go to the hospital pharmacy, they have to teach you, right? If you go to a community place, they hand it out like it's candy. But it's an interesting point, and I think let's talk about naloxone for a second. And I'm certainly not picking on any hospital, but who do you think can use this naloxone in a hospital? Who could administer it?
Oh, I know. It has
See,
to be
tricky.
you're right. It has to be a healthcare provider.
Oh.
But we've got in now, so the peers can do it too. So any hospital employee can administer it where I work.
Really?
Yeah.
Wow.
It's because that's what they did at CAMH. They had a CAMH a couple of years ago. So we got their documents, and then we brought them over to our place. And we had 5-6 meetings, and now we have actually I don't. Sorry. Oh my God, I'm so sorry. I was talking about who can dispense it. You're talking about who can administer it.
Yeah. Who can save the life?
Yeah, well, I mean, I think we both agree that it should be anyone, right? It should be anyone who can administer it. And I think in the corporate worlds, in a lot of these places, they're rolling out naloxone kits like they do defibrillators. Yeah.
Well, so if you've been able to do it with if you've got the dispensing thing, then you guys are ahead of others. If a peer, I didn't know you have peers.
Yeah.
Amazing. If
I mean, they don't work with me directly.
But they're allowed to distribute the naloxone in your hospital. All right, we won't hold you to that.
Yeah.
But
well, we have the meetings. Maybe we're waiting for certain others.
Then that's good. That's good, and that's one thing. But again, it's like who can use the naloxone, and we struggle with that, and who can we would want maybe security should carry it with them. They don't. And it's and even administering it if somebody is in a state that they need naloxone, we should be calling a code, and the code team should come.
Yeah. I remember I had one in my office just for teaching purposes, and I felt like horrible wasting one just for teaching purposes so people could see it. But then there was a code blue overdose. The resident that was in my office, I was off site that day, just took it and administered it, and I was like, okay, great, and I'm glad that happened. But it's like it's you don't know when you're gonna need it and how. And then for me, the part I struggle with is what point do you administer it? Because I see so many people that are passed out, not responding to things. Maybe passed out is not the correct term, and I literally have to look, do I see something moving? Then I start to yell, I sort of nudge a bit, and then if they're sort of breathing, most of the time they tell me to fuck off. It's happened 3 times where I'm like this, then one guy wasn't responding, I didn't have a kit, I start calling on, and then he's like, leave me alone. I'm like, okay, so because it's hard to tell, right? Is somebody actually breathing or not? So this is embarrassing. At what line do you give it? Because if you give it, the person's gonna be so angry with you, right? When they wake up. And Sometimes they are angry with you, and I like to err on the caution of I don't if somebody's responsive. I've not administered naloxone.
You haven't?
No,
okay.
Not to somebody who's passed out and.
To someone who isn't passed out, have you administered it?
No, but I've seen patients where it was administered to maybe a couple hours before.
Okay. So yeah. So I've done that a number, probably about, I don't know, maybe 3 or 4 times, I think, in total. But I've only done the nasal, I think, once, and the other 2 or 3 times was the IV. Not IV, IM. It's it's scary stuff. In the sense that, so one guy kind of swung at me. I think it was the first guy swung at me, but I think it was more of like a reflex, not because it was with intention. I won't go into too many details, but it was in a clinical setting, and one of the latest times, and it was the individual needed three doses of it, two nasally and then one IM.
So when you administer it, does the person stop breathing fully?
Yes. And no, not in all cases. Just completely non-responsive, and do that kind of sternum rub with the knuckles, right, where you're like going up and down.
When there's no response to the sternum rub, that's when you give it.
That's when I've given it. I think other people have different. I was kind of I'm kind of astonished sometimes. Like I was originally in one of the naloxone trainers, because I went through that extra 8-hour course to be a trainer of it, and it's people react differently to different situations.
Just out of curiosity, so you've got the trainer training. Are you allowed to administer naloxone to patients in the hospital setting, or is it when you leave the building you're allowed to? Oh, you can't say. Let's not say. Okay.
Even as somebody who sits at those policy tables, I'm not even sure to answer your question. I'm not sure what the actual policy even is, and I kind of err on, let's try to keep this person in front of me alive. If there's a tool that I have that's going to keep them alive,
that's what I do too.
I'll ask for forgiveness later than permission before.
What I've learned so far is that harm reduction is really about allowing people in hospital settings, allowing people to complete their medical care. It's really about helping people remain comfortable, and there's a lot of structural barriers. And one of the first ones with naloxone, it's very interesting when you start to look at how it's used in different facilities, who's allowed to dispense it to people, whether you dispense it to the person who uses drugs or their friend, or if they know someone who uses, all those kinds of things. And then how to use it is important to figure out as well. And then once you get into a large organization where there's a lot of medical legal liability, you have to figure out who is it that can administer it, right?
Yes.
In what way? And is it something where you have an official policy, or you just sort of whatever that might be, and the same thing. Okay.
Yeah, I think. Hospitals need official policies.
Yeah. And let's go through the supplies then as well, right? Because so naloxone is, it's a major part of harm reduction. But it's not as major, I think, because when people were talking about make sure you give them an naloxone kit, make sure you give them a script for something, part of me is like, this doesn't deal with the day-to-day pattern of use, and it doesn't resolve the harm in the day-to-day pattern, right? Because it's not like people need naloxone 5 or 6 times a day, right? Like it's the emergency piece.
Naloxone. I think people say that. I say it all the time too. But it's like, it's one piece that you can do, right? It's something you can do. It's not. It's certainly not. I don't know what it is. If it's 10% of harm reduction, that would be a lot, right? Because not everyone. Naloxone only works for people that have an opiate overdose. But a lot of people right now don't. There's people have benzo overdose. Doesn't work for that.
You have benzo overdoses. You have stimulant overdoses where the heart stops.
You got a million scenarios where it's not.
Seizures,
it's not going to help. Not going to help at all. And I know that we've focused a lot, and we should, on the opiate crisis, but that's not the extent of the substance use.
It's partially really upsetting to me too, because people who live and work in places where overdoses have been common. I think there was this one talk I saw, this is more than a decade ago. It was a guy who was from Chicago, And they'd been trying for like at least a decade or more to get naloxone where you can just pick it up at the pharmacy. You don't have to. And then when they finally got it, like at some place you could pick it up, it cost like $50 to $100 per shot, right? Like it was just like absurd how it was done. And the drug itself is so cheap, right? But it's the delivery system, and there's so much more than our people need with the naloxone. And the problem is that when you put such importance on one thing, and you deliver, it's like my hands are washed. I've done my duty.
You got your naloxone. What else you
got
want?
your naloxone. I'm gonna go home and sleep.
My work here is done.
Yeah, my work here is done. And so naloxone is something, it looks like it's been a fight for a while to have those barriers reduced and access increased.
Yes.
And there's tons of places of success, but even the places that aren't where they eventually want to be, they're moving in the right direction.
Yeah.
What are the other items? Because when I first went to the works, like, I don't know if it was 2015, 2016, because you may not know this, all cities have a public health facility that offers supplies. Back then, all they were giving were needle kits, and they were giving some kind of smoking kit.
So I'm going to stop, if I can stop you right there. Harm reduction is not about items. It's about a process, right? It's about it's about changing the way people think about people who use substances, right? It's about tackling the stigma that people are facing every day, feeling illness in their home to the point where they're, so sick that they will die in their house, as opposed to dealing with the stigma of going to the emergency room and facing that scorn, or what they perceive to be scorn of our emergency room colleagues, either the security or the admins or the nurse or the doctor or anybody along the way, right? And that whole, if you don't look right, like if you don't, it's like, are you really sick, or what are you here for, right? Are you drug seeking? Because you were drug seeking the last time. You came about pain like 3 times in the last month, so I think this is, you're just looking for drugs, right? That, changing the dynamic of that engagement, that's what harm reduction is to me.
Yeah, and that's gonna be another process in itself, right? Because it's gonna be another process, because when I think about people who work in the emergency, in their minds, people that have car accidents, that are trauma, because of the way the healthcare system's broken and how people don't have a place to go, they'll see people with sniffles, they'll see people with small bruises, people that have like chronic pain but they can't see their doctor. And so a lot of times in the emergency, I think the emergency departments are very good at keeping you alive in the short, although they still need to work on people who use drugs, figure out how to keep them alive. But in general, right, if you take addiction, they're good at like figuring out, hey, is this person going to live or die in the next day? Let me connect them where they need. And if it's more of a chronic condition, they do the other supports. And they have a little bit of that, what was the word you used? Like frustration or something, or like, it was a negative word, which is sort of true, because you get annoyed, right? It's like, say if, what would it be like? I'm
going to interrupt. I'm going to give you an example, and I'm going to put you on the spot here, because
Sure.
we just talked about this. We talked about you have a cut on your face, right?
Yep.
And you talked about we ended up both talking about what happens when you had a cut on your head, and one of the challenges is that the pattern of hair, if you get your stitches in the wrong way, you may end up with a little tiny bald spot.
Yeah, a scar.
Yeah.
I've got like 4 scars on my head.
Okay, good.
4 scars, and
Not
now they use like hairs and glue, and there's no scar, and almost no scar, and then the hair grows.
Perfect.
But I've got these patches, so every time I shave my head, it just you see all these. And they're like, were you okay as a kid? You bumped into a lot of things.
But not a shocker on that either. But do you really think that our folks, the folks that we support, do you think they're getting the same kind of scar treatment that you got? Yeah. Your stitches look pretty clean there.
They're very clean. I was
very
shocked
clean.
how clean it was. Yeah.
And do you think our folks, do they look that clean?
No.
And why don't they look that clean?
I don't know. I mean, I don't know. Yeah.
You don't know?
Yeah. God, you can see what side I'm on, right? Because you don't want to criticize our colleagues, and stuff like that. But it's one of the things. There's a different level of attention to detail depending on who the person is. When the aristocrats or the wealthy get a cold, the poor die of pneumonia, and I think like stuff for. It's uncomfortable to think about how different people get different levels of care based
Right.
on who they are, what they do, the choices they make. And when there's a feeling consciously or unconsciously around personal responsibility where the person caused this, as opposed to them being a victim,
Right.
there's a different level of TLC that comes in that interaction.
Right. So you're not to overshare, but this happened in a basketball game, not because you were intoxicated and fell on your face.
Yeah, but I sometimes leave that open, right?
Sure.
For interpretation. Yeah.
So
I was playing in the basketball game, and I was at fault. I was overly aggressive
Okay.
on the defense.
But again, it's just as self-induced or just as much involvement as one of our guys who just nods off and falls on his face, right?
Yeah, because it's not like they're not getting a knife and cutting. And even if they were getting a knife and cutting their face open, there needs to be TLC in that care. But these are people that are not choosing to have the harms. They're coming in because usually people force them. A lot of people that use drugs will literally stay at home for like 4 or 5 days. Like with these horrible wounds. The worst part that about me visiting the works and the public health facility in Toronto is that I heard all these stories of patients that would come in and see the wound care nurse regularly because they trusted the wound care nurse, but their infections were getting worse. They needed to come to hospital, and they were refusing to go to the hospital. They didn't feel safe going there, right? So all these structural barriers you bring up are real. They're uncomfortable for me to process and deal with because I work in the larger institute. I've worked in like 4, 5, 6 different hospitals.
Yeah.
Right. And it's for all of them. It's not like there's one that's hey, like we love going to this one, right?
Right.
Of this or that.
So. And I'm not trying to single you out for it because I'm a product of this system too now. So if I work in a hospital, and most of the time when I needed medical care,
Yep.
I get treated at a different level, right? But not all the time, right? So
I remember a couple of times stuff that came up.
Yeah, so there's I come back to an example where I've had to navigate the hospital myself because I still have some residual effects because of my substance use. One of them is I get infections relatively easily, perhaps because I'm immunocompromised, and that happens as well. So I had a tooth infection where my eye was closed and my I was starting to affect my breathing, and so they put me on IV antibiotics, and that's fine. So I went to my dentist. My dentist told me to go to the hospital. The hospital put me on IV antibiotics pretty quickly. So because I knew the doctor there at the time, so it went pretty well. But until the one point when the nurse came by and said, I'm here to start your IV. And I said, okay, that's great. But I got to tell you, the only place I have an accessible vein is in my foot. And she looked at me in disbelief, and this is somebody who knows me. I still had my hospital badge on. I was at work at the time even. That smile was turned upside down into a frown, and it was me now. Everything came flooding back to me. I don't know that her care was substandard. I'm not suggesting that, but I didn't feel as welcome in the place, and everything rushed back on me. So that trauma that I experienced from substandard care for a number of years, which I believe I received because of my substance use, came flooding back to me, and it was like, I'm not doing an IV in your foot. I have to go talk to the doctor, and I have to get permission to do that, and so for me, it was just all that stigma came running back to me. Now, was it any different to get the IV in my foot or my arm? Not really.
Well, we'd have to see if there was policy differences or if it was a personal difference. I don't know.
No.
I hear I'm defending the hospitals like that.
Yeah.
Like that's I'm sorry. It's probably very invalidating.
Defend it, because it took her 90 minutes to come back, and then somebody else had to start the IV in my foot ultimately, and but for me it was like, I don't know if I want to go through that again. Right. So if I didn't want to go through that again.
Just the process of letting them know.
Just the process of letting them know. Just the process of not being an equal anymore. Right. I'm not a member of the club anymore because I'm one of those guys that needs IV in their foot because they injected too many drugs.
God. Okay.
So I'm a less than, right. And and that was really tough. So I bring that story up because this is what people struggle with. People struggle with being that exception, right? It's like being labeled as the substance user. And I'm somebody who speaks of it. That's what I do for a living. That's what I'm sitting here talking about.
Yep.
That's all I do.
Yeah.
So think about the person
who doesn't
do any of that. That does it complete. It's a private experience.
And they know the frown is going to come.
Yeah, the frown is going to come.
Or whatever nonverbal. It may not even be a frown.
Well, you're not going to get it first line. It's going to they have to go back and they have to get permission. And then even that permission isn't transferred. So I was in what's called the, rapid program or something, or, no wait program. I don't know what they called it at that time.
For the IV.
Yeah, with the IV. So you come back every 8 hours to get the thing. So you would think at least while the permission that she got, and it took 90 minutes to get, would be transferable to when I came back 8 hours later. No, it's not.
Oh, every time you have to have the conversation a couple of times.
Normally I wouldn't need to see a doctor to get the new IV. One doctor orders it, you come, the nurses hook you up. But
was it a nurse who put the IV in?
Yes.
So they have the skill set.
Oh, absolutely, they have the skill set.
So I was assuming they might not have. I'm trying to find reasons why the barriers would be there, but it sounds like it is stigma. It is judgment.
Let's assume they have a policy that it's a non-conventional spot. But the point I'm making is that why couldn't the doctor's consent from one day transfer to 8 hours later? So you got to find another doctor now.
Yeah.
And there's only one doctor on the service. It's 11 o'clock at night, and that's fine. That's what happens. And so then I've got to wait again to get reapproved to get that. So, and how many people are going to wait?
Yeah. No wonder none of my patients want to get blood work.
Yeah.
No wonder none of them want to get blood work. Because they're definitely not using ultrasound guided things in these clinics. And for people who use drugs, even if you had an ultrasound guided way to get the IV in, you'd still miss a couple of times, right? Depending on where you're trying to go
you'd
for.
Miss all of them. As somebody who is kind of almost a non-existent or non-accessible vein system in their body, I used to have to get it done through interventional radiology.
This is such a great conversation, and not because of your suffering, because I feel like shit, right? Because I fully don't appreciate. I keep in my mind, I always run to what's within my control and what can I do. But the problem is the way I sometimes say that. People don't feel validated for their current state, right?
Well, no, I think there's not a lot you can do. You don't run the hospital. I mean, many people think that, though. Many people think that the doctors run a hospital.
We definitely don't have to do what they tell me.
No.
For a lot of things, I do what they tell me.
I mean, there are some doctors.
And there's ways to talk, right? Because you can't just start screaming and yelling in meetings. You have to be strategic, and it takes time.
Yeah.
But you gave me a phenomenal idea just here. So we're gonna have a drop-in addiction clinic, and why not have that at the same time that we have some kind of a phlebotomist or a nurse or whatever who's trained in using the ultrasounded guided IVs.
Sure.
And just so it's part of the expectation, right? So it'll be either every Wednesday morning, because I think that's the only way to get proper blood work, right? And it would take time. It would take time and trust and all that stuff. But you can't send somebody who's injected drugs for a few years or a decade in to see an average phlebotomist, right? Let alone a resident who's it's different. When some family members trained in India, they would do thousands of these. They had 1 year where all they were doing was taking blood. Here, I've maybe done 3 IVs in my life. You know how absurd that is. A medical doctor only having done 3 or 4 IVs.
I don't want you drawing my blood.
I don't draw blood. So I have an idea that I have to take to the next level. And also hearing your story helped me build some compassion for these people that I see that just don't want to leave blood work.
Yeah.
And I'm not convinced that mass trainings of an organization with 10,000 employees, I'm not convinced it actually works. I think it can be part of it. But I think there has to be something else that happens on the ground around an evolution of philosophy, especially when we're talking about attitude shift, because we're not talking about skill shift unless we frame the training as a skill shift. We're talking about an attitude shift. And
it's got to be constant. It's got to be ongoing. It's got to be recurring. It's got to be mandatory. So this is what
It's got to be mandatory.
It's got to be absolutely has to be mandatory. Absolutely has to be mandatory. And I've been, and it's got to be kind of at ground level, right? It can't just all be off a module. Although I'm a huge fan of having modularized training it's got to be a relatable training, right? So you have to have somebody doing these trainings that knows their shit. That's my opinion of it. I think there has to be somebody they can relate to.
Yeah.
I think, obviously I'm a little bit biased. I've literally trained, thousands of people on this now at this point. and the smaller the group, the better.
Yeah.
It has to be all inclusive. Nobody's immune to the training. So housekeeping, 100%.
Yeah, I like that.
There's nobody that should be excluded.
I agree with that 100% because when we talked, when I saw this talk by Bill Miller, and he was trying to create a warm environment, he trained everyone in motivational interviewing.
Yep.
And I mean, harm reduction, it's different than motivational interviewing, but there's something about that philosophy that's different than this is what you need to do to get care.
Yes.
It's a different approach than that, right? And,
yeah. Yeah, no,
I like the idea of the janitors, the security, everyone being trained in this thing.
100%, right? And hopefully it can be done by somebody on your team, right? There should be somebody on your team who can do it, right? That has perhaps been there. I mean, I guess I'm a little bit spoiled in doing that, in that I can, I've actually had the opportunity of training some of the nurses that provided care to me as a patient, which is unique and powerful. And for both of us, and you could say, well, did you call them out on their stuff? And I'm like, I didn't, but that wouldn't have gotten me anywhere.
No, and the funny thing is, I hear those questions all the time, and I just sort of ignore them, and then when other people are there doing the care, they try to call them out on stuff, and then I'm like, I need to do more. Like the whole idea, there's a few situations like that where I'm just.
But I don't find that works. So what I do is all their care isn't bad. I compliment them, on the relationship. I even point out, you probably don't remember me.
Is this the training, or is this when you're a patient?
No. I've never done it. When I'm a patient, I'm a patient. I don't tell them what I do.
Oh, so when you're training others, you validate all the stuff they do well first?
Yes. I went for the people that I've had interactions with that actually provided care that could be improved upon. Let's put it that way. I build on the good things that they did, and show them just by example. Like, I think the biggest thing for them is that they write people off, right? They think, I believe, this is how I believe, because I see them giving different care to different people, and I think for our population, what they tend to do is say, this is all self. This is
what you've heard sort of off the record, or you've seen indirectly?
No, I just draw this conclusion
based on the nonverbal.
I think the reason they treat people with addiction in a different way often is because they don't consider they're worthy of their best care, perhaps, right? Because they did it to themselves. It's self-induced, and they're not going to. The biggest part, they're not going to get better anyway. So what's the point?
Oh my God, you think people believe this?
I 100% think that.
So this we can change, and harm reduction is a great way to change it because it changes what the goal is.
Well, right, and just to build on that point, this we can change because when I'm standing in front of them, then they've seen it change.
Yeah,
they saw it change. They saw somebody, and that's what I say. I say, look, I work with you now. I pay taxes now. I pay the same. I'm in the same union you're in. So it can change, right? So I get it. It's not always going to change, but the person that uses substance is just as worthy of care as everybody is, as the doctor is, right?
Yeah.
And the doctor shouldn't get better stitches than the person with substance use. They should get the same quality of care, right? Yeah. And we should all get the same quality of care, right? Because we're all worthy of that same level of care. Anyway, I'm a little passionate about this, but.
No, but I think this is a very important thing, because no one's going to share what beliefs they have inside, and people can tell when the words don't match the nonverbal, right? The nonverbal or the actions or those kinds of things, and I think I agree with all you said. I never considered the fact that people write people off, that people, or maybe I did consider it, but I just don't like to have it fresh in mind that they cause this themselves, and then they're not going to get better. And part of me was, and I do this all the time, right? Because I try to think, what's the task that can be done? Like just when I see people who use drugs where they need to see their family doctor and they don't want to, they say, oh, they don't listen. They think I'm drug seeking and this, and I'll be like, well, no, look, you have this one symptom. This is the test we need. How do we get them to order? So immediately go to those steps. And for this here, I'm thinking about in the trainings and stuff, because there's the attitude shift that you talked about. There's other people that I've worked with where maybe they need the attitude shift too, but they also don't know the steps. They don't know the steps how to help. And I think once you bring in a harm reduction philosophy, all of a sudden you're changing the goalpost, because the goalpost isn't that the person never uses drugs again. They have a meaningful life. They pay taxes, although maybe it's arguable if that's I think, I don't know. Like, I just...
Paid taxes, meaning they're not a drain on the system, they're a contributor to the system. That's the only reason I bring up paid taxes, right? Because they see themselves as, a lot of people say, "Look, why is my tax dollar supporting other people?" I hear that all the time.
You hear that all the time?
I hear that all the time from the healthcare workers directly.
From the healthcare workers?
Yeah, I hear that from my colleagues. Absolutely.
I don't know, because I remember growing up. My dad's a bit weird, but he's like, he was like, why not pay? Like, I think it was what is it, 50 some percent? I don't know what it was back then, right? It's probably gone up. And he's like, they pave the roads, they give schools, they give education, and we care for the weak, right? We give them hospital care, medical care, all that stuff. And even though I think it was only in the 80s it started, that's one of the reasons I love being in Canada, even with whatever tax rate and stuff like that. So yeah, so sorry. Just I don't like hearing these truths. It's uncomfortable to hear.
Yeah.
But the where I was going with that is that if we set the target goal different, right? So what's the target, right? The target is that this person stays for the 2 weeks, gets enough antibiotics that they can transition to oral, or the person stays for this time, then they get some kind of safer place to go afterwards. It's very different than them changing their entire life. And I think that's a doable goal. And then the other thing, JP, that I think is important, I don't know how to frame this, is that people are so worried, and part of it is we've had this training over the last decade or two where doctors were trained to provide meds for pain, and it caused a devastating effect when people were fully treated for their pain at really, really high doses. And then it caused a worse effect when they stopped providing those medications.
Yes.
And the correction or the overcorrection or whatever the term is in hospitals has been, we don't want to give drugs to people that are drug seeking, right? And I don't know, there has to be a way to share that, hey, for these people who use drugs, the ship has sailed, they have an addiction. You giving them one hydromorphone, one Percocet is not going to change that addiction. Let's get them comfortable, right? And so I've made it a practice to shift. I don't give opiates for pain or withdrawal. I give it if the person's awake and asks, right? Like, I think that's it, but still it's almost like you have... So my point is that with these things that you're talking about, part of the changing of the approach is what you talked about, right? So, and even if you just say it for a small portion, right? If they're working beside you to manage cases, because one thing they told me at the works was, you can't make your institution harm reduction capable unless you have someone with lived experience on your team. That's what they said. And I believe that true, right? And so part of it happens with you being on the team. Part of it happens with you sharing your story. Part of it happens with you giving some tips and suggestions. And I also think we have to shift what the goal of care is and what are the specific steps we provide. And it starts with the comfort. How do we help them be comfortable? And how do we get them to get that life essential medical care?
Yeah.
Right?
And it all starts with treating them like human beings.
Yeah.
That's where it all starts.
Yeah. So, I mean,
that's where it all starts. So if you use that as the overarching kind of treat everyone like a human being.
Yeah. So
I know you don't want. That's one of these uncomfortable truths, because you don't want to accept that people don't treat people with like human beings.
Well, there's that. And I also think that I don't know why I keep going to steps, because so at home, every now and then my wife is like, "You're not showing any consideration," and then I'm just like, "How would I show consideration? Like, how would you?" And I think there's some things where, like, maybe it has to be an internal process. Maybe we have to reflect that, say, hey, if I see a doctor or a politician or a CEO versus if I see somebody who's homeless, who's swearing at me and spitting at me, what's different in the care that I provide? Maybe it has to be an internal process. I also think I think we can come up with steps, right, on how to show that you care.
You can come up with steps, but beyond that, the overarching thing is that, and you know it when you see it. It's hard to articulate it, perhaps, what not being treated like a human being is, but you know it. You've seen it in your own organization. You've seen it in my organization. You see it every day.
I've seen it sometimes in how I act, and then somebody has to call me on it, right? Like, for when I'm a little bit different than I.
Well, I've never seen you do that, in fairness, but I think it's people, when you know it, when you see it, you know it, and that's where it starts, right? So
Yeah.
and there's no amount of training that's going to do that, but you're right, having somebody with lived experience on the team is a great first step. That's great advice that they gave you, and that's probably the reason I got on the team was because of that advice and because you listened to it. So you're not part of the problem here, right? But you're trying to navigate how to be part of the solution.
The thing is, all these trainings, when you make it mandatory, when you make it ongoing, when you make it this iterative process of growth, you avoid it. I find for these trainings that I go to, everyone's already drank the Kool-Aid. Everyone sees these people with compassion, care, and then they don't know what steps to do when they're with the person, right? And so maybe that's why I also go to the steps. The other reason is that, I've worked with a few people who are internal medicine doctors. They're very, very good at what they do. And even for things like, grief or like someone passing away or like giving advice, they work in acronyms, right? So they'll come up with some kind of acronym, like they'll like give and like, get this. And then some people work better with steps. And part of me thinks that for the emerge or for surgeons or stuff like that, if we can come up with the checklist, right? I think it would be good to figure out what it means to be. So I'll just give you one example, right? So when I went to the works for the first time, because I was struggling, like, treat them like, and I was like, what does that mean? What does that mean? And then this guy who was phenomenal in teaching me a bunch of stuff was like, look, when the person walks in the room, so at the entrance for the works, we have the waiting area, everyone looks up, makes eye contact, smiles, and then goes back to their work, right? They have a clear path to the harm reduction supplies that people can, this is probably before COVID, clear path to the harm reduction supplies that they can go get. The fifth time or the sixth time the person comes say, hi, I'm Pat, or hi, I'm Jim, nice to meet you. And then the seventh or eighth time, they always do the same thing. The person comes in, eye contact, smile, go back to what they're doing. And then they say, hey, in case you're interested, we have like a wound care nurse here. We have this if you want to see them. And so I think I think it's important to figure out how to unpack the how. And so the example would be, for that case you brought around the foot things, right? This is going to sound horrible. It's almost like, see the person's suffering, see the person as a human being, smile on the outside, figure out how to stop the harm first, or how to support, what's the TLC and love and care that you provide to a family member who is here, and then explicit sort of a steps. But you're right though. When you teach someone the steps, I've seen interviews where people are following all the steps. It doesn't feel like the person cares. And there's something, and that's why like good actors, they can completely embody the experience, right? Mm-hmm. Whereas, in medicine, we're not trained as actors. We're trained as checklist followers.
I guess sure. If you want to make a checklist, if a checklist helps certain people to do it, I've not done that, but I think what you've described is kind of how you'd be treated in a Tim Hortons too. And they seem to have managed that quite well. So it's feeling welcome and all those
Throw
things.
in one or two comments, compliment something they're wearing. I mean, the challenge is that it would have to be authentic, right? Like,
well, that's the thing, right? So if it's a check, what's your problem? I already said, how are you doing? And I made eye contact.
I've heard that before. I've heard like variants of that before. When people do these interviews, we give them feedback, and they're like, "I don't understand what was wrong. I did this, and I don't know how to give a feedback saying it looks like you didn't really care and you were focused on your checklist." And so in medical exams, they used to have something. They might still have it where they have half of it is a checklist, and then half of it is global impression. And the interesting, I mean the pro checklist group side in me notices that when somebody hits all the checklists, usually the score is a little bit higher versus lower. But there is that, does the person genuinely care? Are they genuinely interested and invested in getting this person better? Or do they just need to figure out what their decision tree is? Yeah. And the patient knows every single time. Yeah.
Yeah. I think exactly, and I think maybe that's a kind of a good point to sort of wrap things up on this. Is that I think that this population, a population that I've been a member of for a long time, has a pretty good bullshit filter.
Of course,
and if somebody's trying to bullshit us, we've had the rug pulled out from underneath us for so long in every scenario you can possibly imagine. We've been disappointed and deceived and taken advantage of. So if you think you're going to come at us with a, something that's going to, you think you're going to fake it and get through it, it's probably the wrong population to try to fake it on. But if you come at us with sincerity, with normalizing what we're doing and not judging us, then, we're pretty open to that.
Yeah.
And just not treating us like we're a different class of citizen. Like we're just as worthy of care as you are, as your mother is, and as your cousin is, and your colleagues are. And I think you'll find that we can be a willing recipient of care, and we can be good patients too if you treat us well.
Very good patients. Yeah, very good patients. Yeah, so I think what you just said is something that I'm going to have to listen to a couple of times. Because there was a lot that was there, and it felt very real, and I appreciate you saying those things. To finish up today, just because I think this is, unfortunately, this is going to be an ongoing, iterative, collaborative process.
Yeah.
I would say it's semi-mandatory in my mind, right? Where I just really try to get harm reduction, and I really try to fully embody it, right? Because I do believe it's an ongoing journey, and every year there's more that I need to self-reflect. So I'm going to just summarize my take-homes for today, and then let's revisit this in a month or two, because there's a few things that are in my mind that I'm trying to roll. These are the lower hanging fruits, but eventually there's going to be a lot of other stuff. So today what I've heard from you and from our dialogue. Harm reduction is important in hospitals because we want people to get the medical care without them leaving. And it starts with really accepting someone for who they are and the choices they make, regardless whether it matches our views and values or not. And we really want to facilitate and support them getting that care, and comfort's a big part of it. There's a lot of structural barriers, and in the community environments, they have a lot of workarounds for it. I mean, they've still had to work for it. You can't just do anything you want in the community. But the larger an organization gets, the harder and harder it is to really make shifts in practices, right? Especially when the risk is somewhat unclear. We know the risk of not providing something is quite high, but we know that from our personal experience, right, clinically. But for some reason in medicine, they don't weigh the risk of not providing it as much. And then you also talked about the trainings, right? How there's value in seeing somebody who's been successful, what in the components of the training. And I really like those 4 or 5 words that you said off the top of your head. I'm going to have to listen to that again. And how people can really tell when you're authentic or not. And even though I was focused on the steps, what we need and the checklist, and you can itemize it, you can't do it without having that full connection in some way. There are a few other things that came up as well, but I think this is a good start for me, and thank you for having this impromptu conversation around harm reduction. I think even though my intentions are good, right? I think
100%.
there's a long way that I think I need to go personally, and also in how I interact with others and spreading that message, because it's probably not enough for me to give a certain level of care and ignore when I hear from colleagues about different levels of care they're giving, right? And so that's something that I'll need to work on. Yeah, and let's keep this going.
Absolutely. Thanks for listening. Okay. Take care.